Explain the 8LARA principle in radiation protection. How does it apply to both patient and occupational safety in radiology practices? Answer. The 8LARA is low as reasonably achievable. Principle is a key concept in radiation protection, aiming to minimize radiation exposure to both patients and healthcare workers. It is guided by three fundamental principles: justification, optimization, and dose limitation. Justification requires that any exposure to radiation must have a net benefit, meaning the expected diagnostic or therapeutic benefit must outweigh the risks associated with radiation exposure. Optimization involves making every reasonable effort to reduce exposure while still achieving the desired medical outcomes. This includes utilizing appropriate shielding, distance, and protective equipment, and employing techniques that reduce dose without compromising image quality. Dose limitation involves setting limits on radiation doses received by individuals, particularly occupational exposure, adhering to regulatory guidelines set by organizations like the NRC, Nuclear Regulatory Commission, and OSHA, Occupational Safety and Health Administration. Effective implementation of ALARA not only enhances patient safety by reducing unnecessary exposure, but also protects radiology staff from potential occupational hazards associated with long-term radiation exposure. Compare and contrast the safety protocols for MRI and CT imaging concerning patient health and potential risks. Answer. Both MRI, magnetic resonance imaging, and CT, computed tomography, imaging have distinct safety protocols driven by their different mechanisms and associated risks. MRI safety protocols. MRI uses strong magnetic fields and radio waves, posing risks related to magnetism. Patients with certain implants, e.g., pacemakers, metal implants, are at risk, thus thorough screening is essential. Gadolinium-based contrast agents, though generally safe, carry risks of nephrogenic systemic fibrosis (NSF) in patients with renal impairment. Safety guidelines recommend assessing kidney function before administration. Precautions include ensuring no metallic objects are in the MRI room, monitoring patient comfort, and providing adequate communication during the procedure. CT safety protocols. CT utilizes ionizing radiation, which poses risks related to cumulative radiation exposure. Therefore, dose optimization techniques like iterative reconstruction and modulation are critical in reducing radiation doses. Safety protocols necessitate thorough patient history assessments to avoid adverse reactions to iodinated contrast agents, such as allergic reactions or contrast-induced nephropathy. Special considerations should be given to vulnerable populations, such as pediatrics, where doses should be adjusted according to body size and age. Overall, while both modalities of safety measures, MRI focuses on non-ionizing risks related to magnetism, while CT emphasizes minimizing ionizing radiation exposure. Define the concept of linear energy transfer, LET, and its significance in radiation dosimetry. How does LET influence the biological effectiveness of different types of radiation? Answer. Linear energy transfer, LET, is a measure of the energy transferred by radiation to the material it passes through, expressed in units of keV. It plays a crucial role in radiation dosimetry and biological effects of radiation. Types of radiation. High LET radiation, e.g., alpha particles, transfers energy more densely and causes significant ionization along its path, leading to higher biological damage. Low LET radiation, e.g., X-rays, gamma rays, transfers energy less densely, resulting in less ionization per unit length. Relative biological effectiveness, or BE. LET is integral to calculating the RBE, which compares the biological effectiveness of different types of radiation. For instance, high LET radiation is typically more effective at causing biological damage compared to low LET radiation for the same absorbed dose. Understanding LET helps in therapeutic radiation planning, as higher LET radiation can be used effectively for targeting cancer cells while sparing surrounding healthy tissue. Mr. Adams is scheduled for a CT scan but has expressed concerns regarding the use of iodinated contrast due to a previous allergic reaction. What steps should the healthcare provider take to ensure informed consent is adequately obtained in this situation? Answer. In the case of Mr. Adams, the healthcare provider should take the following steps to ensure informed consent is appropriately obtained. Thorough assessment. Obtain a detailed medical history emphasizing previous allergic reactions and specific responses to iodinated contrast agents. Assess renal function through laboratory tests, as renal impairment can exacerbate the risk of contrast-related complications. Informed discussion. Provide comprehensive information about the CT procedure, including potential benefits and risks associated with iodinated contrast, ensuring Mr. Adams understands the implications. Discuss alternative imaging modalities that may not require contrast, e.g., MRI or ultrasound, and the potential diagnostic limitations of foregoing the CT scan with contrast. Documenting consent. Ensure that Mr. Adams' concerns and preferences are documented in the medical record. If iodinated contrast is deemed necessary, consider pre-medication protocols, e.g., corticosteroids and antihistamines, to minimize allergic reactions, and obtain documented informed consent after addressing all concerns. This process ensures patient autonomy, aligns with ethical practices in radiology, and adheres to the principles of informed consent as outlined by medical ethics guidelines. Describe the common types of artifacts seen in CT imaging and their potential impact on diagnostic accuracy. How can radiologists identify and mitigate these artifacts? Answer: CT imaging artifacts can significantly impact diagnostic accuracy by mimicking or obscuring pathology. Common types include beam hardening artifacts, caused by the differential attenuation of X-rays as they pass through dense structures, leading to dark bands or streaks. Mitigation includes using proper calibration and selecting appropriate reconstruction algorithms. Motion artifacts result from patient movement during scanning, creating blurring or streaking in images. Solutions involve instructing patients to remain still, using shorter acquisition times, or employing gating techniques for dynamic studies. Partial volume artifacts occur when a voxel contains multiple tissue types, leading to averaging and inaccurate representation of tissues. Use of thinner slices and optimized reconstruction algorithms can minimize these effects. Aliasing artifacts arise from insufficient sampling, resulting in repetitive patterns or false high contrast edges. Preventative measures include using appropriate case-based sampling strategies and recon algorithms. Radiologists must be adept at recognizing these artifacts to avoid misdiagnosis and apply corrective measures in imaging protocols. What are the key legal considerations a radiologist must keep in mind when handling patient data, and how do HIPAA regulations impact this practice? Answer: Radiologists must navigate several legal considerations regarding patient data management, predominantly influenced by HIPAA, Health Insurance Portability and Accountability Act regulations. Key aspects include confidentiality. Radiologists must ensure that all patient information remains confidential. This entails limiting access to authorized personnel only and employing secure communication channels when discussing patient cases. Informed consent. Legal obligations necessitate obtaining informed consent before performing any imaging procedure, ensuring patients are aware of risks, benefits, and alternative options. Data security. Under HIPAA, radiologists are required to implement administrative, physical, and technical safeguards to protect patient information from unauthorized access and breaches. This includes using secure passwords, encryption for electronic records, and conducting regular risk assessments. Breach notification. In the event of a data breach, radiologists must adhere to HIPAA's breach notification rules, promptly informing affected patients and taking corrective actions. Record keeping. Compliance with legal retention policies for medical records is crucial. Radiologists should be aware of state-specific laws regarding the duration for which patient records must be retained. By understanding and adhering to these legal considerations, radiologists can mitigate risks associated with malpractice and ensure compliance with federal regulations. Discuss the approach to developing a differential diagnosis based on imaging findings in a case of suspected pneumonia. What imaging characteristics would lead you to differentiate between typical and atypical pneumonia? Answer: developing a differential diagnosis in suspected pneumonia involves integrating clinical history, laboratory findings, and imaging characteristics. Key steps include imaging findings. Typical pneumonia, often presents with lobar consolidation on chest X-ray or CT showing airspace opacities, bronchial wall thickening, and possible pleural effusion. Atypical pneumonia may exhibit more diffuse patterns, such as interstitial infiltrates or nodular opacities, without the classic lobar consolidation. Viral pneumonias may show ground glass opacities or reticular patterns. Clinical correlation. Evaluate patient symptoms, e.g., fever, cough, sputum production, and laboratory tests, e.g., blood cultures, PCR for specific pathogens. History of recent travel or immunocompromised status may guide considerations for atypical pathogens, e.g., mycoplasma, chlamydia, or viral causes. Further imaging. If findings are indeterminate, follow-up imaging, e.g., repeat chest X-ray or CT, or additional studies, e. G. Bronchoscopy may be warranted to clarify the diagnosis. Outline the key components of a quality assurance program in a radiology department. Why is QA critical for patient safety and diagnostic accuracy? Answer: a comprehensive quality assurance program in radiology encompasses several essential components: equipment calibration and maintenance, regular calibration and preventive maintenance of imaging equipment, e.g. X-ray machines, CT scanners, to ensure optimal performance and accuracy, keeping maintenance logs and ensuring compliance with manufacturer specifications and regulatory standards. Image quality assessment: implementing routine image quality assessments to evaluate parameters such as contrast, spatial resolution, and artifact frequency, utilizing standardized protocols and phantom studies to benchmark performance. Radiation dose monitoring: monitoring and documenting radiation doses for patients to ensure compliance with ALARA principles and regulatory limits, utilizing dose tracking software to identify trends and optimize protocols. Staff training and education: regular training sessions for radiologists and technicians to keep abreast of best practices, advancements in technology, and safety protocols. Encouraging a culture of safety where staff can report concerns and participate in quality improvement initiatives. Incident reporting and analysis: establishing a system for reporting and analyzing adverse events or near misses to identify root causes and implement corrective actions. Promoting transparency and accountability in addressing issues. Quality assurance is critical for patient safety as it directly influences the accuracy of diagnosis, minimizes unnecessary radiation exposure, and fosters trust in the healthcare system. Describe the process of treatment planning in radiation oncology. What are the key considerations in developing a radiation treatment plan for a patient with breast cancer? Answer: treatment planning in radiation oncology is a systematic process aimed at delivering effective doses of radiation while minimizing exposure to surrounding healthy tissues. Key steps include patient simulation. Initial patient simulation involves immobilization techniques and CT imaging to define tumor location and surrounding anatomy. Correct patient positioning is essential for reproducibility during treatment sessions. Contouring target volumes, identification and delineation of the tumor, GTV. Gross tumor volume and surrounding areas, ETV. Clinical target volume, PTV. Planning target volume using imaging data, consideration of lymphatic drainage patterns and regional nodal involvement in breast cancer. Dose prescription, determining the total dose and fractionation schedule based on tumor type, stage, and prior treatment history. Common practice for breast cancer involves a total dose of 4550 Gi to the whole breast with potential boost doses for the tumor bed. Treatment planning, utilizing advanced planning systems to create a treatment plan that optimally delivers radiation while sparing normal tissues, e.g. heart and lungs, evaluating plan quality using metrics such as conformity index, homogeneity index, and dose volume histogram, DH, verification and quality assurance, performing plan verification, including film dosimetry or electronic portal imaging to ensure accurate dose delivery, continual assessment of treatment delivery throughout the course to adjust for anatomical changes or unforeseen circumstances. This comprehensive planning approach ensures the effective treatment of breast cancer while prioritizing patient safety and minimizing potential complications. Discuss the role of PET-CT in oncological imaging. What advantages does PET-CT provide over traditional imaging modalities, and what challenges does it present? Answer: PET, positron emission tomography, computed tomography, has emerged as a crucial tool in oncological imaging, integrating metabolic and anatomical data. Key advantages and challenges include: advantages, metabolic information. PET provides functional imaging by detecting metabolic activity, allowing for the identification of malignant lesions based on glucose metabolism, e.g. using FDG, fluorodeoxyglucose, improved diagnostic accuracy. The combination of metabolic and anatomical imaging enhances the accuracy of tumor characterization, staging, and treatment response assessment compared to traditional modalities like CT or MRI alone. Therapeutic decision-making. PET-CT plays a pivotal role in treatment planning, e.g. radiation therapy, and evaluating treatment response, guiding oncologists in making more informed decisions regarding patient management. Challenges: cost and availability. PET-CT is often more expensive than standard imaging modalities, which may limit access in some healthcare settings. Radiation exposure. Although the radiation dose is relatively low, patients still receive exposure from both PET and CT components, necessitating consideration of the ALARA principle interpretative complexity. The interpretation of PET-CT images requires specialized training, as false positives, e.g. inflammatory processes, can complicate the clinical picture. In summary, PET-CT represents a significant advancement in oncological imaging, offering enhanced diagnostic capabilities, although challenges related to cost, access, and interpretation must be addressed. Explain the key differences between conventional fractionation and hypofractionation in radiation therapy. How do these differences influence treatment outcomes, particularly in terms of normal tissue toxicity and tumor control? Answer: conventional fractionation typically involves delivering radiation in small doses, usually 1.8 to 2.0 Gy per fraction, over several weeks. Hypofractionation, on the other hand, delivers larger doses per fraction, typically exceeding 2.5 Gy over a shorter duration. Tumor control. Hypofractionation takes advantage of the lower Ab ratio in some tumors, e.g. prostate cancer, which implies that larger doses per fraction might result in better tumor control for these lower Ab tumors. Normal tissue toxicity. Hypofractionation can potentially increase the risk of normal tissue toxicity, particularly in tissues with higher Ab ratios, e.g. skin mucosa. However, technological advancements like IMRT can help mitigate these risks by improving dose distribution. Clinical applications. Hypofractionation has been used successfully in breast cancer and prostate cancer treatments. For example, the CH-HIP trial demonstrated non-inferiority of hypofractionated radiation therapy in prostate cancer compared to conventional schedules. Biological effectiveness. The linear quadratic LQ model helps explain the biological effects of radiation, where hypofractionation causes greater biological damage per fraction to cells, which may be beneficial for certain cancers but harmful to healthy tissues. Mr. Anderson is a 55-year-old patient diagnosed with a high-grade glioma. His oncologist has recommended radiotherapy. The treatment plan involves using intensity-modulated radiation therapy (IMAT) to deliver a highly conformal dose while sparing critical structures like the optic chiasm and brainstem. However, the initial dose volume histogram DEH indicates that the dose to the optic chiasm exceeds tolerance levels. What adjustments can be made to the treatment plan to reduce the dose to the optic chiasm without compromising tumor coverage? Answer: several adjustments can be made to optimize the treatment plan. Re-optimize the IMRT plan by modifying the optimization parameters. The dose to the optic chiasm can be reduced. This involves adjusting the weighting or priority assigned to the optic chiasm in the inverse planning algorithm. Use VMAT, volumetric modulated arc therapy. VMAT, which delivers radiation in a continuous arc, can further improve dose conformity and spare the optic chiasm more effectively than traditional IMRT in some cases. Adaptive radiotherapy, ART, allows for real-time modifications to the treatment plan based on imaging performed during the course of therapy. This technique can help reduce dose to OARS organs at risk by adapting to anatomical changes, reducing PTV margins. If imaging shows limited tumor motion, shrinking the planning target volume, PTV margins may help reduce the dose to surrounding OARS like the optic chiasm without affecting tumor coverage. Proton therapy. If available, proton therapy may be considered. Protons have a Bragg peak that allows for better sparing of adjacent normal tissues, including the optic chiasm, compared to photons. The key is to balance tumor coverage and OAR sparing, adhering to the tolerance doses as recommended by QUANT. See guidelines, e.g. optic chiasm maximum dose 55 Gy for conventional fractionation. What are the primary mechanisms by which radiation therapy induces cell death in cancer cells? How does the cell cycle phase affect radiosensitivity? Answer: radiation therapy induces cell death primarily through the following mechanisms. DNA damage. Radiation causes double-strand break DSPS in DNA, which are lethal to cells if not properly repaired. The formation of reactive oxygen species, ROS, amplifies this effect. Cell cycle effects. Cells are most radiosensitive during the G and M phases of the cell cycle. This is because in these phases, cells have less time to repair DNA damage before entering mitosis, leading to mitotic catastrophe. Conversely, cells in the late S phase are more radioresistant due to the high efficiency of homologous recombination repair mechanisms during this phase. Apoptosis and necrosis. Radiation can also trigger apoptosis in cells with intact P pathways. Tumors with P mutations might require higher doses to induce apoptosis, and instead necrosis may become a more prominent mode of cell death. Mitotic catastrophe. Radiation can cause cells to attempt to divide with damaged DNA, leading to mitotic catastrophe and cell death. In clinical practice, radiosensitizers, e.g., cisplatin, may be used to exploit these mechanisms, further enhancing the effectiveness of radiation by increasing DNA damage or interfering with repair mechanisms. What are the key differences between low-dose rate LDR and high-dose rate HDR brachytherapy for prostate cancer in terms of their mechanisms, delivery methods, and clinical outcomes? Answer: the primary differences between LDR and HDR brachytherapy are mechanism and dose rate. LDR brachytherapy delivers continuous low-dose radiation over several days or weeks using permanently implanted radioactive seeds, e.g. iodine-125 or palladium-103. HDR brachytherapy delivers high doses of radiation over minutes using temporarily placed catheters with high-activity sources, e.g. iridium-192 in a fractionated schedule delivery method, LDR. The seeds are implanted permanently, with the radiation slowly decaying over time. HDR. The source is temporarily placed in the prostate and removed after each treatment, allowing for more precise dose delivery and flexibility in adjusting the treatment plan. Clinical outcomes, LDR. Suitable for low to intermediate risk prostate cancer, offering convenience with a one-time implant. Side effects can include urinary irritation and a higher risk of long-term erectile dysfunction. HDR allows for greater dose conformality and sparing of adjacent normal tissues, e.g. rectum, bladder. HDR brachytherapy is often combined with external beam radiation for high-risk prostate cancer. Both techniques aim to deliver a high dose to the prostate while minimizing dose to surrounding organs at risk. ASTRO guidelines recommend selecting the technique based on patient-specific factors, including tumor stage, prostate size, and patient comorbidities. Dr. Green, a radiation oncologist, is treating MS. Lewis, a 40-year-old patient who received radiation therapy for Hodgkin lymphoma 15 years ago. She now presents with a breast mass that is suspicious for a radiation-induced secondary cancer. What factors should Dr. Green consider in determining whether the breast cancer is likely to be radiation-induced, and how should this affect MS? Lewis's treatment plan. Answer: Dr. Green should consider the following factors to determine if Lewis's breast cancer is radiation-induced. Latency period. Radiation-induced cancers typically have a latency period of 1015 years. Given the time since her initial treatment, it is plausible that this breast mass could be secondary to the radiation therapy. Field of previous radiation. Hodgkin lymphoma treatments often involve radiation to the mediastinum and chest, which can increase the risk of breast cancer, particularly in women treated at a young age. Dose and volume of radiation. Higher doses and larger treatment volumes correlate with an increased risk of secondary malignancies. Dr. Green should review Lewis's radiation treatment records to assess her previous dose and feel genetic predisposition. Some patients, especially those with genetic predispositions, e.g. BRCA mutations, may have a heightened risk of radiation-induced malignancies. Genetic testing may be warranted in this case. Impact on current treatment. Lewis's history of prior radiation may limit her options for further radiation in the same area. Alternative treatments such as surgery, chemotherapy, or hormone therapy might need to be considered depending on the extent of disease. What are dose-limiting toxicities (DLTs) in radiation therapy, and how do they impact treatment planning and patient outcomes? Discuss common DLTs and strategies to mitigate their risks. Answer: dose-limiting toxicities (DLTs) are adverse effects that occur when radiation doses exceed thresholds that can lead to significant harm to normal tissues, thus limiting the dose that can be delivered to tumors. Understanding and managing DLTs is crucial for optimizing treatment outcomes while minimizing risks. Impact on treatment planning. Dose constraints. DLTs dictate the maximum allowable dose to organs at risk, cause influencing the overall radiation treatment plan. Treatment modifications. If a patient is at risk for developing DLTs, treatment plans may be adjusted to decrease dose to certain areas, which could result in modified fractionation schemes or alternative treatment modalities. Common dose-limiting organs. Lungs, risk of pneumonitis with dose limits around 30 Gi for conventional fractionation. Heart. Cardiac toxicity becomes a concern with doses above 3040 Gi, particularly for left-sided breast cancer radiation. Strategies for mitigation. Dose volume histogram, DE. Utilizing DVH helps visualize the distribution of radiation dose to both target volumes and ores, guiding treatment adjustments to minimize DLT risk. Adaptive radiotherapy, adjusting treatment plans based on changes in anatomy or tumor response can further help to manage LTS. Clinical guidelines. Organizations like the American Society for Radiation Oncology (ASTRO) provide dose constraints and recommendations for managing DATS, emphasizing the importance of individualized treatment strategies. Discuss the acute and late radiation toxicities associated with external beam radiation therapy. How can these toxicities be managed in clinical practice? Answer: radiation toxicities are categorized into acute and late effects, each requiring distinct management strategies to improve patient quality of life and treatment outcomes. Acute toxicities. These occur during or shortly after treatment, typically within weeks. Common acute toxicities include dermatitis, skin irritation ranging from erythema to desquamation. Management strategies include using emollients, topical steroids, and educating patients to avoid irritants. Mucositis, inflammation of mucosal surfaces, especially in patients receiving head and neck radiation. Symptomatic relief can be achieved with analgesics and mouth rinses. Fatigue, a prevalent symptom managed through education on energy conservation and encouraging physical activity tailored to individual tolerance levels. Late toxicities. These may appear months or years after treatment and can include radiation fibrosis, scarring and functional impairment in irradiated tissues. Management may involve physical and occupational therapy to enhance function and quality of life. Secondary cancers. Increased risk of secondary malignancies necessitates long-term monitoring and patient education about potential signs and symptoms. Management strategies. Prevention. Providing education on skincare during treatment, nutritional support to prevent or manage mucositis, and conducting pre-treatment dental evaluations in patients receiving head and neck radiation. Monitoring. Regular follow-up visits to assess for early signs of toxicity allow for timely interventions and adjustments to treatment plans. Symptomatic relief. Administration of analgesics, anti-inflammatory medications, and topical agents can help relieve symptoms associated with both acute and late toxicities. Clinical guidelines from organizations such as ASTRO provide recommendations for managing radiation toxicities, emphasizing the need for a patient-centered approach. Compare and contrast the use of stereotactic body radiation therapy (SRT) and conventional external beam radiation therapy in the treatment of lung cancer. Discuss the implications for treatment planning and patient outcomes. Answer: stereotactic body radiation therapy (SRT) and conventional external beam radiation therapy (EBT) differ significantly in their approach to delivering radiation, with implications for treatment planning and clinical outcomes. Treatment delivery: SRT delivers high doses of radiation in fewer fractions, typically 1/5, utilizing advanced imaging to precisely target small tumors, such as early-stage non-small cell lung cancer (SLC). This method minimizes radiation exposure to surrounding healthy tissue. Conventional EBT typically involves lower doses administered over a larger number of fractions, e.g. 3040, which may not achieve the same level of tumor control in early-stage disease due to broader treatment fields. Dosimetry and plan: SRT requires detailed imaging and sophisticated treatment planning techniques, such as image-guided radiation therapy (IGIT) and respiratory gating, to ensure accurate delivery of radiation while sparing normal tissues. Conventional EBT, while effective for larger or more advanced tumors, it generally lacks the same level of precision, which can lead to increased radiation exposure to adjacent normal structures. Clinical outcomes: SRT clinical trials, e.g. RTOG 236, demonstrate excellent local control rates, 90% for early-stage lung tumors with acceptable toxicity profiles. SBRT also offers shorter treatment duration and improved post-treatment quality of life. Conventional EBT, although effective for larger or advanced tumors, it may result in low local control rates for small peripheral lung tumors compared to SBRT. The choice between SBRT and conventional BRT should consider factors such as tumor size, location, patient comorbidities, and preferences, with multidisciplinary team discussions guiding the treatment approach based on established clinical guidelines. Explain the concept of adaptive radiotherapy (ART) and its significance in the treatment of patients undergoing radiation therapy. What technological advancements have facilitated the implementation of ART in clinical practice? Answer: adaptive radiotherapy (ART) refers to a dynamic treatment approach that allows for modifications to the radiation treatment plan based on real-time changes in patient anatomy or tumor characteristics during the course of therapy. This adaptability is crucial for optimizing radiation delivery and improving patient outcomes. Significance of ART: personalization. ART enables tailoring of treatment plans to reflect changes such as tumor shrinkage or weight loss, thereby optimizing dose distribution and improving therapeutic efficacy. Enhanced outcomes. Studies show that ART can improve clinical outcomes in various cancer types, especially in scenarios where tumor movement or anatomical changes significantly impact treatment precision, such as in prostate and head and neck cancers. Technological advancements. Advanced imaging techniques. Tools such as cone beam computed tomography (ET) and magnetic resonance imaging (MRI) facilitate real-time monitoring of anatomical changes, providing essential data for plan adjustments. Automation and software development. The evolution of automated treatment planning systems enables rapid replanning processes, making it feasible to adapt treatment in response to patient changes. Motion management technologies. Innovations like respiratory gating and tumor tracking systems enhance the accuracy of radiation delivery in moving tumors, significantly improving the precision of ART. The implementation of ART in clinical practice represents a significant advancement in radiation oncology, with ongoing research aimed at further integrating these technologies to ensure personalized treatment plans based on individual patient needs. What is the significance of organ at risk or contouring in radiation therapy, and how does it affect treatment planning? Discuss the methods used for OAR delineation and the guidelines that govern these practices. Answer: organ at risk or contouring is a crucial component of radiation therapy that focuses on accurately defining normal tissues at risk of receiving radiation exposure during treatment planning. The significance of OAR contouring lies in its impact on minimizing toxicity while delivering effective radiation doses to tumors. Significance: dose limitation. Precise OAR contouring allows radiation oncologists to establish dose constraints for surrounding healthy tissues, ensuring that radiation doses do not exceed safe thresholds, thus preventing acute and late toxicities. Optimized treatment planning. Accurate delineation directly influences treatment planning and optimization, enabling the delivery of adequate doses to the tumor while minimizing radiation exposure to ores. Methods of OAR delineation. Imaging modalities. Utilization of CT, MRI, and PET scans aids in visualizing both the tumor and adjacent normal structures. Integrating multimodal imaging enhances contouring accuracy. Protocol-driven contouring. Established protocols from organizations like the RTOG and ASTRO provide standardized criteria for OAR delineation, specifying anatomical landmarks and thresholds for contouring. Guidelines and best practices (QUANTE). See guidelines. These guidelines outline maximum tolerated doses for various ores, providing benchmarks that inform treatment planning and optimization. Consensus guidelines. Recommendations from the American College of Radiology (ACA) and the Radiological Society of North America (ARSNI) further delineate best practices for OAR contouring, enhancing consistency and safety across treatment facilities. In conclusion, careful OAR contouring is essential for effective radiation therapy, ensuring that treatment is both safe and effective while minimizing the risk of complications. In computed tomography (CT), what is the principle behind iterative reconstruction techniques, and how do these methods help in dose optimization? Answer: iterative reconstruction techniques in CT imaging involve repeatedly refining the image by comparing the acquired data to an assumed image and adjusting for discrepancies. Unlike traditional filter-back projection (FBP), which uses a single-step process to create the image, iterative methods gradually improve image quality by reducing noise and artifacts. Iterative reconstruction is beneficial in dose optimization because it allows for lower radiation exposure while maintaining high image quality. By reducing the quantum noise that arises at lower doses, these techniques enable radiologists to use reduced X-ray tube currents without compromising diagnostic accuracy. This method is particularly advantageous in pediatric imaging or for patients requiring multiple scans where radiation dose must be minimized. Key guidelines, such as those from the American College of Radiology (ACA), emphasize the use of dose optimization strategies like iterative reconstruction to achieve the ALAI as low as reasonably achievable, principle in CT imaging. Mr. Anderson, a 55-year-old male, has been scheduled for a brain MRI to investigate possible multiple sclerosis (MS). He has a history of kidney disease. His referring physician has ordered an MRI with gadolinium-based contrast agents (GBA). Given his condition, how should the radiologist proceed with contrast administration? Answer: in this scenario, the radiologist must assess the risk of nephrogenic systemic fibrosis, NSF, a potentially fatal condition associated with gadolinium-based contrast agents in patients with renal impairment. The American College of Radiology (ACA) and European Society of Urogenital Radiology (ESSA) guidelines recommend evaluating the patient's glomerular filtration rate (GFR) before administering GBCA. If Mr. Anderson's GFR is below 30 ml none on 0.73 mm, the use of gadolinium should be avoided unless absolutely necessary. Alternative imaging techniques, such as non-contrast MRI or other modalities like CT or ultrasound, may be considered. In cases where gadolinium must be used, a macrocyclic GBCA, which is less likely to release free gadolinium ions, should be preferred. If his GFR is above 30 ml on 0.73 m, gadolinium can be administered cautiously, and proper hydration before and after the scan is recommended to support kidney function. Additionally, the lowest possible dose of GBCA should be used to minimize risks. This decision-making aligns with the 2017 ACR Manual on Contrast Media Guidelines, which prioritize patient safety and the assessment of renal function when administering contrast agents. Explain how Doppler ultrasound can be used to evaluate blood flow in a patient with suspected vascular disease, and describe the physical principles behind Doppler effect in medical imaging. Answer: Doppler ultrasound is a non-invasive imaging technique used to assess blood flow through vessels. It works on the principle of the Doppler effect, where the frequency of sound waves changes as they reflect off moving objects, in this case, red blood cells. If blood is moving towards the transducer, the reflected sound waves have a higher frequency positive Doppler shift, and if moving away, the frequency decreases negative Doppler shift. This method is particularly useful in evaluating vascular diseases such as arterial stenosis or venous insufficiency. By analyzing the frequency shifts, the speed and direction of blood flow can be quantified. High velocity flow may indicate stenosis, narrowing of the vessel, while absent or reversed flow can signal a complete blockage or severe vascular disease. The American Institute of Ultrasound and Medicine (AM) recommends Doppler ultrasound as the first-line modality for vascular assessment, emphasizing its value in detecting and quantifying hemodynamic abnormalities without the need for ionizing radiation or contrast agents. Describe the common causes and solutions for ring artifacts observed in CT imaging. How does the physics of image formation in CT contribute to the formation of these artifacts? Answer: ring artifacts in CT imaging typically occur due to calibration errors or malfunctioning detector elements. They appear as concentric rings on the image and are caused by inconsistencies in the response of individual detector elements as the gantry rotates around the patient. The physics behind this artifact relates to how the CT system reconstructs images from multiple projections. If one detector is underperforming or overperforming relative to others, it introduces errors into the data, manifesting as rings in the reconstructed image. Solutions include calibration. Regular calibration of the CT detectors helps maintain uniformity in response and reduces the likelihood of ring artifacts. Detector maintenance. Identifying and replacing faulty detectors is a long-term solution. Software correction. Modern CT systems include algorithms to correct for minor detector inconsistencies automatically. What is the difference between T and T relaxation times in MRI, and how does each affect image contrast? Answer: T relaxation times refer to the processes by which protons in the body return to equilibrium after being disturbed by an MRI radio frequency pulse. T relaxation time, also known as longitudinal relaxation, is the time taken for protons to realign with the magnetic field. Weighted images highlight fat-rich tissues, which recover quickly, appearing bright. This sequence is particularly useful for anatomical imaging as it provides good contrast between different soft tissues. T relaxation time, also known as transverse relaxation, is the time taken for protons to lose phase coherence with each other after the pulse. Weighted images emphasize fluid-rich tissues, such as edema or cerebrospinal fluid, which appear bright. T imaging is often used in pathology to identify abnormal fluid accumulation, as most pathological processes result in increased water content. The choice between T and T weighting depends on the clinical question. T is preferred for structural detail, whilst T is ideal for detecting fluid and edema. According to the ACR guidelines, MRI protocols are selected based on the suspected pathology to maximize diagnostic yield. Dr. Morgan, a radiologist, receives a patient who underwent a PET scan for cancer staging. The scan shows unexpected tracer uptake in the myocardium. What are the potential causes of this finding, and what should be Dr. Morgan's next step? Answer: unexpected myocardial uptake in PET imaging could be due to several factors, including physiological uptake of the tracer, which can occur in metabolically active tissues like the myocardium, especially if the patient has not adhered to pre-scan dietary instructions. Cardiac pathology. such as inflammation or infiltrative disease, can also result in increased tracer uptake in the heart. The next step for Dr. Morgan should be to review the patient's preparation for the scan, e.g., ensuring they followed the low-carbohydrate diet recommended before FD, GPE, T imaging, and consider correlation with other imaging modalities like MRI or echocardiography to assess for cardiac abnormalities. If physiological uptake is suspected, repeat imaging with stricter preparation protocols may be required. Following the SNMMI Society of Nuclear Medicine and Molecular Imaging guidelines, ensuring proper patient preparation is crucial for reducing artifacts and improving the diagnostic accuracy of PET scans. How does the pulse echo principle work in ultrasound imaging, and why is it critical for image formation? Answer: the pulse echo principle is fundamental to ultrasound imaging. In this process, an ultrasound transducer emits high-frequency sound pulses into the body, which travel through tissues and are reflected back by tissue interfaces, e.g., boundaries between different tissue types. The transducer detects these returning echoes and converts them into electrical signals, which are processed to form an image. The time delay between the pulse emission and the echo reception is used to calculate the depth of the reflecting structure based on the speed of sound in soft tissue, approximately 1,540 meters. The strength of the returning echoes determines the brightness of the corresponding point in the image. This principle allows for real-time imaging of soft tissues and is crucial for diagnostic purposes in areas like obstetrics, cardiology, and vascular studies. The AIUM guidelines highlight the importance of the pulse echo method in non-invasive diagnostics, providing high-resolution imaging without ionizing radiation. Discuss the concept of image post-processing in digital radiography and how it enhances diagnostic capabilities. Answer: image post-processing in digital radiography refers to the manipulation of digital images after acquisition to improve their quality and enhance diagnostic interpretation. This process can involve various techniques, such as windowing and leveling, adjusting the brightness and contrast of the image to optimize the visualization of specific anatomical structures. For example, soft tissue images can be enhanced by adjusting the window level to emphasize differences in tissue density. Image filtering, applying algorithms to reduce noise, enhance edges, or remove artifacts. Common filters include Gaussian, median, and edge enhancement filters, each serving different purposes to improve clarity. Multiplanar reformation (MPR). In CT imaging, MPR allows for the reconstruction of images in various planes, sagittal, coronal, etc., from the original axial slices, providing comprehensive views of the anatomy and pathology. 3D reconstruction. Advanced post-processing techniques can create three-dimensional images from TWAD slices, aiding in the visualization of complex structures and improving surgical planning or treatment evaluation. The American College of Radiology (ACA) emphasizes the importance of appropriate post-processing techniques to enhance diagnostic accuracy and reduce the likelihood of misinterpretation due to poor image quality. Mrs. Chen, a 70-year-old female, presents with persistent abdominal pain. A CT scan reveals a 4 cm mass in the pancreas. What are the imaging considerations and follow-up recommendations for further evaluation of potential pancreatic cancer? Answer: in the case of a suspected pancreatic mass, several imaging considerations and follow-up steps should be taken. Characterization of the mass. A CT scan with pancreatic protocol should ideally include multiphasic imaging, non-contrast, arterial and venous phases to assess the vascular involvement, local invasion, and metastases. Contrast-enhanced CT is typically the first step in characterizing pancreatic lesions. MRI consideration. If the CT results are inconclusive or if there is a need for better soft tissue contrast, an MRI with hepatobiliary-specific contrast agents such as gadoxetate can provide additional information about the mass's nature and its relationship with surrounding structures. Endoscopic ultrasound US may be employed to better characterize the mass, obtain tissue samples via fine needle aspiration (FNA), and assess for vascular invasion. It is particularly useful for evaluating small lesions that may not be clearly visible on CT or MRI. Staging. If pancreatic cancer is confirmed, further imaging to assess metastases such as a PET scan may be warranted. This imaging can help evaluate distant spread and guide treatment options. Follow-up guidelines. According to the ACR guidelines, the management of pancreatic masses should be multidisciplinary, involving oncologists, surgeons, and radiologists to determine the best course of action based on imaging findings and the patient's overall health. By utilizing a combination of imaging modalities, radiologists can accurately characterize pancreatic lesions and support appropriate management strategies. Explain the significance of radiation dose optimization in pediatric imaging and the specific strategies that can be employed to achieve this goal. Answer: radiation dose optimization in pediatric imaging is crucial due to the heightened sensitivity of children to ionizing radiation and their longer life expectancy, increasing the risk of developing radiation-induced cancers. Strategies for dose optimization include ALARA principle. The as low as reasonably achievable principle is foundational in pediatric imaging, emphasizing the need to minimize radiation exposure while obtaining diagnostic quality images. Age and size appropriateness. Tailoring imaging protocols based on the child's age, size, and the specific anatomical area being imaged helps ensure that radiation doses are kept to a minimum. This may include using lower kVp settings and adjusting the mAh mass based on patient size. Use of pediatric-specific protocols. Many imaging facilities develop specific protocols for pediatric patients that include optimized settings for various procedures, ensuring that the radiation dose is appropriate for the patient's developmental stage. Alternative modalities. When possible, consider non-ionizing imaging alternatives, such as ultrasound or MRI, which do not involve radiation exposure. This is particularly useful for follow-up examinations or in scenarios where the clinical question does not necessitate CT or X-ray. Education and training. Continuous education and training for radiologic technologists and radiologists regarding pediatric imaging techniques and radiation safety are essential. Keeping abreast of the latest advancements in technology and protocols aids in minimizing radiation dose effectively. According to the Image Gently Alliance, implementing these strategies is vital in promoting safe imaging practices for children and mitigating the risks associated with radiation exposure.